Good day. My name is W.Gyselaers. I'm from Hasselt University in Belgium. And first of all, I'd like to thank the organizers of this first virtual International Fluid Academy Days for giving the opportunity to present some of the data of our research project, which has been going on since 2005 now, on maternal critical care. And I'd like to share some new insights with you in hemodynamic monitoring and fluid management. Right, a female body changes tremendously throughout pregnancy. So there's an increase of energy stores in the body. There is a growth of the uterus and its contents. But most of all, there's a very important increase of blood and body water fluids, which is about 30% of the weight gain. And when we consider that the weight gain in pregnancy is around 12 to 15 kilo, then we know that there's an increase of about 4 liters of body waters. Now, this increase is also involved, it contains also intravascular fluids, which means that the maternal heart is under quite some stress by this volume load. And due to this, there is a physiological change of the maternal heart throughout pregnancy, which is basically a combination of concentric and eccentric hypertrophy, actually labeled as physiological hypertrophy. Now, in normal, uncomplicated pregnancy, it has been shown that around 18 to 28% of women do have cardiac signs of eccentric hypertrophy, which means that this normal fluid overload is in fact associated with an extra stress for the heart, and in fact is an overload. Now, this body water volume changes occur in every pregnancy. So regardless of the outcome of this pregnancy, when it is present in uncomplicated pregnancy UP, in early onset preeclampsia EPE, in late onset preeclampsia LPE, gestational hypertension GH, in pregnancies complicated with small for gestational AIDS fetuses SGA, in pregnancies associated with essential hypertension, every pregnancy is associated with an increase of body water volumes. But this does not necessarily mean that every pregnancy is associated with an increase of cardiac output. Most of the pregnancies are. But as you can see here, the red line, which is early onset preeclampsia, is associated with an increase of body water fluids and not with increase of cardiac output. Now, this increase of body water fluids is actually both intracellular and extracellular water. But as you can see here, the extracellular water increases more pronounced than the intracellular water. Now, this means that complications of pregnancies occurring at the end of pregnancy are actually, and we're talking about gestational hypertension on the left column, or preeclampsia in the middle column. So the middle column is late onset preeclampsia and the right column is early onset preeclampsia. These complications occur at the end of pregnancy, but they depend on the circulatory dysfunctions already present in the early stages of pregnancy, in the first trimester. So when there are minor dysfunctions here on the left-hand side, it ends up as a gestational hypertension. When these dysfunctions are a little bit more pronounced, it ends up as a late onset preeclampsia. And when the dysfunctions are more pronounced, as seen on the right side, they end up as an early onset preeclampsia. So this means that this volume overload superimposed above early gestational circulatory dysfunctions actually predispose to development of clinical disease at the end of pregnancy. The second important issue is that venous hemodynamic dysfunction, as can be measured by maternal venous Doppler ultrasonography. Venous hemodynamic dysfunctions are a feature of preeclampsia, but not of gestational hypertension. Or to put it differently, gestational hypertension seems to be a purely arterial problem, whereas preeclampsia seems to be an arterial problem associated with a venous dysfunction. And this is important in the further course of this talk. Now, there are different types of gestational hypertensive disease, and we know that hypertension pregnancy is actually defined according to the conventional criteria in every patient, so higher than when 140/90. But there is pregnancy-induced hypertension or there's chronic hypertension, and chronic hypertension being diagnosed already before 20 weeks of gestation, whereas pregnancy-induced hypertension is new onset hypertension after 20 weeks of gestation. And in this pregnancy-induced hypertension, you have different types. So the gestational hypertension, which is purely hypertension without symptoms of organ dysfunction, basically a lack of proteinuria. It can be preeclampsia, where proteinuria is an important feature, but also other organ dysfunctions can be present. And one severe complication can be eclampsia, which is actually gestational fitting. Now, preeclampsia is now recently recognized as being classifiable in 3 different types. And the first type can be the early onset preeclampsia, where delivery usually is needed before 34 weeks. And this is associated, as already discussed before, with an early first trimester increase of extracellular water with a low cardiac output. And in the late onset preeclampsia, there are actually 2 types. There is one starting with a high cardiac output and a low peripheral resistance, which in the 3rd trimester actually crosses over to a low cardiac output, high resistance state. This has been reported by Bozio in 1999 and is labeled as the crossover late onset preeclampsia. And next to this, there is also a high output preeclampsia type, which means that there is a high cardiac output as compared to normal pregnancies, and throughout every stages of pregnancy, this remains higher than normal. This is reported by Easterling already in 1990. Okay, what do we know about the pathophysiology of early onset preeclampsia nowadays? Well, at implantations, there is a very important modulation of the maternal immune system, which means that there is a combination of immune tolerance against the conceptus associated with inflammation needed to ensure a strong and adherent implantation to maintain for 9 months to come. And this modulation of the immune system is associated with vasomodulators, which is actually a balance between vasodilating and vasoconstrictive agents. And these cause the changes in the maternal circulation, as already mentioned before, but this means that already in the very early stages of pregnancy, in the first trimester already, there are signs of primary endothelial dysfunction, and eventually leading to involvement of the growth of the fetus, mostly associated with IUGR, so intrauterine growth restriction. This is for the early onset type preeclampsia. The crossover late onset preeclampsia basically is related to the intravascular volume overload, which causes a dysfunction of the glycocalyx of the endothelium and the luminal side, as you can see here on the right side, which causes an impaired glycocalyx, due to which the NO pathway is modulated, leading eventually to a vasoconstriction. So here we can see the secondary endothelial dysfunction, an endothelial dysfunction that develops throughout the course of pregnancy. Usually this is associated with a normal fetal growth. And this is again the picture of the crossover from a high output low resistance circulation to a low output, high resistance circulation. And then the third type of preeclampsia, the high volume late onset preeclampsia, seems to be related to the intra-abdominal pressure status. And this could be shown neatly at laparoscopy, so of non-pregnant individuals. A laparoscopy is associated with an increase of intra-abdominal pressure due to the pneumoperitoneum. There was a measurement of proteinuria before, during, and after laparoscopy. And as you can see here, as compared to a control group, which was purely put in Trendelenburg position, during laparoscopy, there is a tremendous increase of proteinuria, which lasts for several hours after the end of the procedure. And here on the right-hand side, you can see that the longer the duration of the procedure, the higher the loss of albuminuria. So this fundamentally is the background mechanism which helps explaining the development of preeclampsia in women who permanently have a high cardiac output status. So actually, by considering the physiologic process of venous congestion, we can explain the symptoms of preeclampsia. Venous congestion may be the result of an increase of intravenous pressure, which is likely to occur in the very early onset preeclampsia. Venous congestion can be the result of volume stasis, which is likely the result in the crossover late onset preeclampsia, or it can be the result of external compression, which is likely the result in the late onset high output preeclampsia. And venous congestion, the pathophysiologic mechanism of venous congestion is that first, congestion causes a microcirculatory dysfunction with a reflex arterial constriction, leading to hypoperfusion of the organ, intra-organ hypoxia, and intra-organ oxidative stress. And this oxidative stress mechanism can stimulate the autonomic nervous system, the endothelium, the lymphatic system, and also can be responsible for the release of extracellular vesicles and microRNAs distributing throughout the different vascular systems in the body, eventually leading to a systemic inflammatory response syndrome and distant organ dysfunction. Now, in this picture, the kidney is taken as an example, but in fact, in pregnancy, it might as well result to a dysfunction, a primary dysfunction of the maternal heart, or an abnormal function of the placenta due to abnormal implantation in the early stages of pregnancy, as already discussed. Right, so considering now these pathophysiologic mechanisms, how can we deal with this in clinical practice? Now, our clinical research project considers the circulation as a circle, as shown over here, where all the components of the circle are interrelated and dependent upon each other. When one component is dysfunctional due to the volume overload or the volume load of pregnancy, it can cause other components to become abnormal throughout the pregnancy. Now, there are several simple methods to measure these components non-invasively. So we're using Doppler ultrasound to assess the maternal venous compartment at the level of kidneys and liver. We use impedance cardiography to measure central and peripheral arterial functions. We use a nail fold microscopic device to evaluate the capillaries at the nail fold. And we use the bioimpedance method to estimate the body water changes. Okay, what gives this as opportunities? So it can help clinicians to target pharmacologic treatments according to the measurements taken for instance, at the level of the heart. And beta blockers are agents known to reduce cardiac output, and they may be well suitable to be used as first choice products in high volume preeclampsia, so high output preeclampsia or high output hypertensions. Whereas calcium channel blockers are associated with an increase of cardiac output, and they may be very suitable to be used in low cardiac output hypertensions. Alpha-methyl-dopa and clonidine are products that hardly change cardiac output at all, and they are suitable for the normal cardiac output hypertensions. When there is not enough response on the conventional antihypertensive drugs, hydralazine, urapidil, or nitroprusside are products that can be used as a top-up. For venodilation, so those women who have hypertension associated with a constricted venous system, they are predisposed to develop preeclampsia. Nitrates are very useful to cause a venodilatation, and even diuretics are up till now considered not suitable for treatment during pregnancy. Actually, when we are dealing with an intravascular overload hypertension, diuretics may well become a first choice product in the near years to come. And secondly, also something important for us obstetricians and also intensivists, there are particular gender-specific differences in the circulatory system between men and women. And we consider the heart as a pump, as shown over here. And we want to increase cardiac output. Men usually do that by increasing forces, by pumping faster or pumping stronger. So they produce an increase of cardiac output by using forces. And women do this more intelligently by simply increasing volumes. They are not increasing the power at first instance, but they are increasing the preload. They are increasing the volume presented to the heart, and these are important differences that are to be considered in treatment. But to know this and to guide this, you need to know, of course, the circulatory status, the state of volume load. Okay, just as a last picture, there's a slide I'd like to show. When you do not precisely have all the information on the fluid management, you can always come across unexpected problems. Okay, thank you very much.